Good afternoon.
Teresa Taylor.
Good afternoon.
Ruth Holton Hodson for John Chung.
Here.
Ralph Cobb for Adria Jenkins Jones.
Here.
Henry Jones.
Here.
Priya Mather.
Here.
David Miller.
Here.
Bill Slayton. Alan LaFaso for Betty Yee.
Here.
Thank you. The next order of business is approval of the of today's timed agenda. Who wants to make the motion?
Move approval. Second.
Moved by Taylor, seconded by Mather. Any discussion on the motion? You have to raise your hands today, folks. Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Executive reports. Ms. Bailey Crimmins, Ms. Lum.
Good afternoon, Mr. Chair, members of the committee, Donna Lum, CalPERS staff. Today I have 4 brief updates to share with you. The first is an update on what's happening with open enrollment within the contact center. Secondly, I'll give you a report on the final 2 CBs that we had in August. And then I'm happy to share some new information about a new surveying methodology and tool that we've been using recently at the CalPERS benefit education events. And then lastly, I'll give you an update on what's happened with some adjustments that we've made with the East San Gabriel retirees. So regarding open enrollment, you're going to have a more comprehensive update on the overall open enrollment and what's happening with the health plan changes soon. But what I wanted to share with you is that obviously this is a very, very busy time for the CalPERS Contact Center. We have had approximately an 18% increase in the number of calls that we received this year over the number of calls that we received last year. Now, that's not surprising to the team. With the various health plan changes that took place, we anticipated that we would likely have more calls in the first 2 weeks. That being said, however, I will say that the team has done an excellent job in terms of fielding the number of calls that we've received. On day 1, we had approximately 6,400 calls offered into the contact center, and well over 80% of them were answered and not abandoned by the caller. Our average call wait time over the past 2 weeks has just been slightly over 5 minutes, and we will continue to see that number drop as we're into week 3 and then obviously at the last week of open enrollment. We are seeing that the calls are taking slightly longer to respond to or to answer the questions, but certainly what we are seeing as well is that our members are calling with a lot of information and have done a lot of research independently on their own. And so we're happy to say that as we are providing the assistance that's needed, we know that we're ensuring that we're also giving them the information that they need to make an informed decision. And then lastly, with regards to open enrollment, I had an opportunity to go over to the contact center last week, and I sat down with one of our agents and listened in to the calls. And it's really insightful when we get to do that because we're able to see, to understand better what the calls are about. But what I experienced in the calls that I sat on was a great amount of gratitude that our members are expressing with regards to the information that they've either received in the mail or that they've researched on the website or that they have gotten from our call center agents. So again, we're heading towards the end. Open enrollment closes on October 5th. And again, I believe that our contact center agents are continuing to be energized, and our members are in good hands when they contact us. Secondly, the CalPERS benefit education events. In August, we successfully completed the remaining 2 CBs for the calendar year. We hosted a CB in San Diego on August 10th and 11th, and we had over 1,200 attendees, which again surpassed the previous record that we had in this area of about 1,000 attendees. Ms. Frost conducted her town hall on both days at the CB, and on Friday she did another one of the Facebook Live events, and I'm certain that she'll give you an additional update on how those events went. Our last CB for this calendar year was at Garden Grove, and that was hosted on August 24th and 25th. We had about 1,200 attendees, and which was slightly higher than the previous attendance that we'd seen in that location. And there too, Ms. Frost conducted another town hall on Friday, and we were able to stream live that on Facebook. We did get a lot of compliments from the members that have been attending these talks that Marcy has been giving at the CBs. Members are commenting on how important it is to hear from our CEO and how grateful that they have been for the opportunity to be present in these. And so as we move forward into the next calendar year, we continue to have plans to use the CBs as an opportunity to continue to reach out to our members and to share the important information that Mrs. Frost has. I just wanted to take a moment to thank all the board members that attended these two CBs, as well as those of you that have attended the CBs throughout the year. As you know, our team is very honored to have you present at the CBs, but more importantly, we know that our members that are attending the CBs also take note and know that you're there, and I know that you also appreciate the interaction that you're able to have with them. Our next CB is scheduled for January 10th and 11th at Seaside, California. All of the CBs that are scheduled for next calendar year are posted on the CalPERS online website. And so for our members that are watching this webcast, you can find the dates at www.calpers.ca.gov. Also related to the CBs, in June, I shared with you that we were going to be launching a new surveying initiative, and this gave our team members the opportunity with tablets to survey those members that survey a sampling of the members that attended the CBs. And it's a great opportunity because we're able to get firsthand experience and information interacting with the members and gathering information on the interaction that they've had with our team. This was just another method of us for being able to get a better understanding of our customer satisfaction with the services that they're receiving. Between June and September, we surveyed over 200 of our members at the CBs, and the overall results were very positive. 96% of those that were surveyed indicated that they were very happy with their experience. 92% indicated that their issue was resolved in a timely manner. And 98% responded yes when we asked if we made them feel like a valued customer. Members consistently provided feedback on the contact center as well as the regional office team members, and as they were commenting, they indicated that they greatly appreciated the thoroughness of the information that they received and the professional manner in which our team members are conducting their customer service. In addition to that, we were pleasantly surprised as many members also expressed that they have been using online resources to answer their own questions. And this is a testament to CalPERS' ability to provide the information members are looking for through the CalPERS website as well as the My CalPERS system. And then lastly, I wanted to give you a brief update on some adjustments that were recently made for the East San Gabriel Valley Human Services Consortium retirees. As you know, these retirees, 74 retirees, experienced a reduction in their retirement warrant. I just wanted to share with you that the 74 ESG retirees had their retirement benefits adjusted and will be receiving a subsequent increase to their retirement allowance. Now, this increase is due to a decrease in the terminated agency's liabilities. The benefit increase was effective for the September retirement period and will be reflected on their October 1st retirement check. All of the 74 retirees were notified of this increase by certified mail last week, and they would have received the certification letter the certified mail no later than Saturday, this past Saturday. Just to give you some insight in terms of what the adjustments look like, about 47%, so 35 of the retirees, are receiving an adjustment of under $25. 27% are receiving an adjustment between $50 and $25. 16% are receiving an adjustment of $50 to $100. And then we had 8% that are receiving an adjustment between $100 and $200. There's one retiree that is receiving an adjustment of slightly over $400. So with that, Mr. Chair, that completes the update, and I'm happy to take any questions that you may have.
Thank you. Any questions or comments? Seeing none, thank you. Before you start, Ms. Bailey Crimmins, I want to note for the record that Ms. Board Member Brown has joined the committee today. Please note that. Ms. Bailey Crimmins.
Good afternoon, Mr. Chair and members of the committee. Leanna Bailey Crimmins, CalPERS team member. For my opening remarks, I have 4 highlights for you today. The first is to provide an update on the CalPERS Health Plan open enrollment efforts. Second is to share some exciting news in regard to employer outreach and retention. Third is to announce the launch of our PPO third-party administrator solicitation. And then lastly, provide you executive highlights on what to expect from the Pension Health Benefits Committee agenda items today. So as Ms. Lum had mentioned, open enrollment is underway. It began on September 10th and will end October 5th. Since the Pension Health Benefits Committee met in June, CalPERS has taken numerous steps to ensure that the 2019 health plan changes were effectively communicated to our members and employers. For example, we mined the data, and anyone who is going to be impacted by an increase in premiums, changes in co-payments, service area, or significant network changes received additional targeted communication from the CalPERS team. Even though overall communication improvements have been made this last year, I want to personally acknowledge that our third-party vendor did erroneously send out a set of letters to PERS Care members. They indicated that there was an enclosure. So at the bottom of your letter, you always see that there's an enclosure. The vendor failed to include attachments. We were alerted of this from a member. The vendor took immediate responsibility and corrected the error, and new member health statements were distributed through the Postal Service to all impacted parties, including an apology letter, and it was received and delivered prior to the September 10th open enrollment date. Second item is employer outreach. In addition to the state of California, CalPERS Health Program contracts with approximately 1,200 public agencies and schools. We believe engagement is key. Therefore, we hold quarterly meetings with our employers, and at our recent August meeting, we covered the 2019 open enrollment updates, including HMO and PPO, and the recently approved VBID for the PERS Select plan. Employers have commented that they find this tremendous value because they get to have face-to-face interaction with CalPERS. The team is currently expecting to plan another employer outreach event in early December. As you're aware, contracting agencies and schools have a 60-day window each year after open enrollment, or after each, the premiums get set in June, to submit a termination resolution. That termination resolution window ended on August 20th, and based on the preliminary data, we're on target to achieve the highest retention rate with our employers in 5 years. I want to personally thank the Health Policy and Research Division and the CalPERS Health Marketing Team, who do an amazing job going out and meeting with the employers and making sure that they have the vital information necessary to share that with their employees and our members. Third item is PPO solicitation. The Health Plan Administration Division is soliciting proposals for a third-party administrator for the CalPERS portfolio of PPO health plans. The solicitation will result in a new 5-year agreement from January 1st, 2020 through December 31st, 2024. As a reminder to any potential bidders that are watching, CalPERS is in a no-contact period. If firms or other parties are interested in receiving information in regarding to the solicitation, they can check out our website, or they can email us at ossd_contractsadmin@calpers.ca.gov. Today, the Pension Health Benefits Committee will cover 4 key topics. The first is the Health Care Reserve Policy. Today, we will be requesting your approval to mature our prior health care fund reserve practices into a policy. The second is an update on the reference pricing pharmaceutical pilot. CalPERS state staff and UC Berkeley had come up with the 3 therapeutic classes. We also had an opportunity to work with RxTE, which is also now known as Active Radar. Those gentlemen are actually in the audience. They shared a wealth of experience and knowledge with us, which allowed us during the research phase to help this board make a final decision to proceed with the pilot. And third, we wanted to share our progress on the healthcare regions. This will be the third of the 5 sessions that we will be having with you on this, and we're specifically sharing today our stakeholder outreach efforts. And lastly, we will be sharing a demo of our new health plan open enrollment app, where we demonstrate how state IT staff rose to the challenge and worked collaboratively with the program to deliver results. And just a fun fact, our first retiree made a health plan change on the open enrollment app from Hayward, California at 4:30 a.m. on the first day of open enrollment. Hats off to the retirees. CalPERS continues to bring the very best experience to our members and look towards technology advancements to help that member experience. And Mr. Chair, I would like the committee's permission for a moment of privilege.
Certainly.
I want to personally thank Dr. Richard Sun for his years of service. He is leaving the state of California to go join the private sector. I don't know how I feel about that, but his last day will be September 28th. He has worked here at CalPERS since 2008, has been our chief over the clinical programs and pill section. He started his state career in 1992 at the California Department of Health Services. He oversaw their Medi-Cal program plans. And something I didn't know about him, that he actually was involved in the CDC Bioterrorism Cooperative Agreement. I want to personally thank him for being a strong advocate on behalf of our members. He implemented the diabetes prevention program that is required across all of our plans, that wonderful population health dashboard that we hold each plan accountable for health outcomes, and he established regulations for post-ACA, and many, many more. So with that, I'd like to turn around and thank Dr. Richard Sun for all his service. Mr. Chair, that concludes my opening remarks. I'm available for questions.
Thank you. And on behalf of the committee, Dr. Sun, we want to wish you well on your new adventure. Wish you weren't leaving us. You brought a lot of insight and great business acumen to this organization, and we certainly appreciate all the help that you've given us over the years. You've taught us all a lot, and your shoes will be big, hard to fill. So thank you and good luck. Anybody else have any questions or comments on this item? Seeing none, moving to item 4, the action consent item. We have one item, that's the approval of minutes. What's the pleasure of the committee?
Move approval.
Moved by Jones, seconded by Taylor. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Item 5 is the information consent items. I have had no request to move anything off of those. We'll take us to action item 6, Healthcare Fund Reserve Policy. Ms. Bailey Crimmins.
So I'm going to go ahead and turn this over to Kathy Donaldson. As we've discussed prior, that we have had a historical practice, and recently we have used reserve monies to buy down the PPO, CalPERS Care, and the Medicare. And so what we're asking today is to mature that practice into a policy which I believe provides additional transparency that our members and our stakeholders are looking for. So with that, I'll turn it over to Kathy.
Very well, thank you.
Mr. Fechner, Chairman Fechner, members of the committee, good afternoon. Kathy Donaldson and Emily Zong, CalPERS team. We are presenting agenda item 6A, which is the Healthcare Fund Reserve Policy. In 1997, a reserving practice was established based on 4 months of premium for the PERS Choice and PERS Care plans, both basic and Medicare. In 2004, CalPERS adopted the National Association of Insurance Commissioners guidelines for using risk-based capital approach to reserving for our PPOs. In 2014, CalPERS flex-funded its HMO plans, which included Anthem HMO, Blue Shield Access Plus, Net Value, Sharp Health Plan, United Healthcare, and Western Health Advantage. And we established fund accounts within the healthcare fund to support the flex-funded plans. Those accounts were meant to pay for any fee-for-service claims, third-party administrator fees, and other fees as required. We have been administering these flex-funded plans since 2014. Today, we are bringing before you a proposed reserve policy that memorializes the reserving practice within the PPO fund accounts. This policy will also address any distribution of flex-funded surpluses that accumulate in the HMO fund accounts. Ms. Emily Zhang will now discuss the previous use of the PPO surpluses, and then we will go back and talk about the HMOs.
Thank you, Kathy. Good afternoon, Mr. Chair and members of the committee. Emily Zhang, CalPERS team members. The PPO reserve are calculated and set aside for each PPO basic and Medicare fund account during the plan year, which is calendar year. The healthcare fund receives premium and investment income and pays out claims and expenses from each fund account. In some years, the incoming fund exceeds the claim and the expenses paid out, creating a surplus. Surpluses occurred mostly due to the conservative cost trend assumption that built into the premium, and those surplus amount has been accumulated over the past several years. Currently, there is no formal procedure in place to review and take action to handle this excess money. However, CalPERS has used this excess fund in the past, and based on board approval. Those include a premium holiday in 2009 in the amount of $260 million, which paid for 2 months of premium for each PPO plan. A CalPERS administrative cost for fiscal year 17-18 in the amount of $40 million. A premium buy-down for PERS Care and Medicare PPO for calendar year 2019. Next slide, please. This slide shows the changes within the proposed PPO reserve policy, which includes the upstate to the current reserve level of risk-based capital, or the RBC level, and all recommendation on the handling of surpluses or deficits on PPO plan fund account. And both items are both reflective in the proposed policy, which is in the attachment 1. Over the past decade, as CalPERS health program evolved and the PPO population has increased, we observed less overall claim volatility and smaller yearly premium increases in recent years. In other words, healthcare costs for CalPERS members are more predictable than in the past. So as a result, the team suggests a lowering of the RBC reserve from the current 300 level, which is approximately 2 months of claim, to the 250 level, which is approximately 1.5 months of claim. Included in the policy also is the proposed methodology of handling potential surpluses or deficits that may occur in the PPO plan fund account. That includes trigger threshold for potential action and the timing for review. During the annual rate development process, the team will review the healthcare fund reserves and compare those to the required reserve amount. There will be 3 scenarios. If the plan reserve fund at the end of the year is within plus or minus 10% of the required reserve, no action will be taken. If the plan reserve fund exceeds 110% of the required amount, a premium reduction will be considered to lower the reserve level back to the 100% of the required. Conversely, if the plan reserve fund falls below 90% of the required reserve amount, an additional surcharge may be considered to be included in the future premium. And this process will be performed on the individual plan level. Now, let me give you an example. Given the required reserve for a particular plan is $100 million, if the amount of the total reserve fund at the end of the year is anywhere between 90 to 110 million, then no action will be taken. If the total reserve fund let's say now it's 112 million, which is above 110% threshold of the required reserve. This will trigger the consideration of using the 12 million surplus toward lowering the future premium. Now, on the opposite scenario, if the total reserve fund falls to, let's say it's now 85 million, which is below 90% threshold of the required reserve, the team will then consider including surcharges into the future premium to make up the 15 million deficits and bring the reserve back to the required level of the 100 million.
Thank you, Emily. And now I'd like to discuss how we're going to handle the flex-funded portion of the reserve policy. For the flex-funded HMO plans, at the end of each calendar year, any surpluses that have accumulated during that year will be reviewed during the rate development process. The team will review each flex-funded plan's financial performance, including capitation, third-party administration invoices paid, fee-for-service medical claims processed, and fee-for-service claims run out, and any other expenses to determine whether there is a surplus in any of the flex-funded accounts. These amounts should be minimal and will roll over to the next year within that 5-year period of the contract. At the end of the 5-year contract, for example, the end of the 2014 to 2018 contract, CalPERS will review each flex-funded HMO plan account, analyzing the revenues and expenditures, claims run out, and contractually required reconciliations to determine whether there is a surplus as we close the 5-year contract. For the flex-funded HMO plans with which CalPERS has entered a new contract, for example, the 2019 to 23 contract, the objective will be to use the 2014 to 18 surplus, if any, toward the same plan. Where CalPERS has not entered into a new contract with an individual flex-funded HMO plan, the goal will be to use the surplus towards the employees and employers from which the surplus was generated. In some instances, such as plan termination, this may entail using the surplus towards a comparable plan. At the end of the 2018 contract on December 31st, 2018, the CalPERS team will execute procedures to close the 2014 to 18 flex-funded HMO contracts, and on January 1, 2019, execute the 2019 to 23 contracts.
In summary, the CalPERS team is recommending this reserve policy for the PPO self-funded health plan to memorialize consistent and transparent approach for detecting and reporting surpluses or deficits within the PPO account in the healthcare fund. It also outlines a methodology for handling any surplus within the flex-funded HMO account. This policy also documents the requirement for reporting and monitoring. In detail, CalPERS team will assess PPO program reserves and will report any changes to the Pension and Health Benefit Committee during the annual rate development process. As we have done in the past, the team will continue to provide semi-annual report to the committee regarding changes to the total assets, reserve, and any surplus or deficits for both PPO and flex-funded HMO program. This policy is a dynamic document that may require revision from time to time based on the changes of the CalPERS health program. CalPERS team will perform evaluation to the policy at least once every 4 years, and we will report back to you.
This slide provides our next steps once the board approves and sets the provisions for the healthcare fund reserve review, the semi-annual financial reporting for all plans, and the 4-year policy review. Chairman Fechner, members of the committee, at this time we invite questions from the committee And at the conclusion, we ask that you accept our recommendation to adopt the reserve policy. And that concludes our presentation. Thank you. for-
Anybody have questions or comments? Turn on Ms. Holton Hodson's microphone, please. I got him.
Fine. Okay. There we go.
You're on.
Okay. So I just wanted to say thank you. I think it is high time we had such a policy. So I'm really glad that we've moved forward, because I know when the question of excess reserves has come up, we're all like, so do we have a policy? And then you explain sort of what we did the last time. And I think, it's also confusing for our members to know, well, if there's reserves, why aren't you giving us a holiday? And we're not in this plan, so why don't we get anything? So the clearer we can make the process, and the clearer that we can make sort of what triggers, what actions, the better. So we appreciate this, and we're in full support.
Thank you. Mr. LaFaso. There you go.
Oh, thank you, Mr. Chair. I ditto Ms. Holton Hodson on the value of the policy. Just, I came in trying to understand exactly what the board role versus the staff role was and how that's going to be implemented. And I'm under the impression that you all make lots of tiny adjustments that maybe we don't see. And maybe you can't answer my question in open session, but are you able to basically tell me when we see numbers during the rate development process, where is the source of funds that fill the reserves? Part of the premium? Is it part of the administrative fees? Where are we going to look for it when you're reporting to us?
I'm going to take this question, Ms. LaFaso. During the rate development process, we try to be really transparent. So in our rate development process, we try to look for the fund balance for each account. Just like what we recommended on the process, we will compare what's the required reserve, and what the individual account, what do they have money in their account. So as what we described, it's over 110%. So in the example, the $12 million, we will be really open and report to you. So how are we going to use the $12 million apply to the premium adjustment in the rate? So we're trying to be really transparent.
Mr. LaFaso, this is Leanna Bailey-Crimmins. Just to remind the board is that the Finance and Admin Committee is where we would actually see the biannually, the actuary gives what the sub-account balances are, and also reports on where the reserve dollar amounts sit, and then that number would then go into the rate development process as we start to establish the premiums. So just wanted to make sure that I reminded the board where that is discussed.
Appreciate that. My question is really focused on the retail experience, not the wholesale account management, but I appreciate the answer. One more question. So if there's a shortfall in the current year and there's a need for more revenues to restore the reserve in the current year, can you walk us through how that process works?
I think, as I kind of mentioned in the example, like in the current year, it's a shortfall currently at this point, and we still have several months of unknown experience to go. If at the end of year we still see a shortfall, let's say it's below 90% of the required reserve, and then we will try to incorporate some surcharge into the premium and trying to bring the reserve back to the required level. But also one thing we need to keep in mind, which is our goal, is to minimize the volatility year over year on the premium volatility. So this is not a very hard formula that, let's say we have 12 million, we have to use the entire 12 million to put into the premium for next year. Or we have a 15 million deficit, then we have to make surcharge toward the next year the premium to make up the entire amount. So we have to keep in mind that we have to minimize the volatility. So this is another item we have to think about. Mm-hmm.
Appreciate it. And I understand there are controls to make a current year adjustment an extremely rare event. So thank you. Thank you, Mr. Chair.
Thank you. Ms. Mother?
Thank you, Mr. Chair. I agree. This is a very sensible, well-thought-through policy. With respect to the adjustments or the surcharges, if we needed to make up a shortfall, that would be in the following year, correct? So we would experience a shortfall in a given, let's say it's 2018, then in 2019, we would, well, it would be for the year later, it'd be for the next rate. So it'd be in 2020 that we would actually experience the surcharge, correct?
That is correct.
Okay.
PIMCA does allow us to make a change, but our practice has not been that.
It's very hard midstream to make a change for members. So, this, as a practical matter, it would be in the rate development process that begins in 2019, but then that would actually be effective for 2020. Okay, that's helpful clarification. Thank you. Well, with that, I'm happy to move adoption of this policy.
Moved by Mather, seconded by Taylor. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Thank you. Brings us to agenda item 7A, reference pricing prescription drugs by therapeutic class. Before we get into that discussion, let me ask a question. Since you guys have been delving into this for quite some time now, do you have enough data, or is there enough data out there to not go into a pilot program, but actually go out to bid on an item and forget the pilot side, and maybe reevaluate it in a year or 2 or 3?
That's an excellent question. So historically, we all understand that premiums matter to our employers and members. And when we establish a premium, it's medical, and it's also pharmacy. And so when we've affected a lot of innovation when it comes to medical, and we've done numerous pilots such as hip and knee, we start out small, we build upon the success, and now we've just, last year we added another 12 procedures to medical. The same falls to suit to the pharmacy side. We have to balance savings plus members' experience. If I focus purely on savings and we don't take a methodical step into making sure that the members' experience at a fixed price for pharmaceutical isn't highly accepted by our membership, that may alter what we end up doing. So we start small and build upon our successes. So that's been our historical practice. I think we have enough data to end up doing the 3 therapeutic classes, but I think if we jumped it to something bigger, we could potentially end up in a situation where our members' satisfaction could be negatively impacted.
But according to you, we could start with just the 3 therapeutic classes and not have to go through the pilot.
Well, we're calling the 3 therapeutic classes a pilot because we're not expecting to have a huge number of savings. It really allows us to test what the members' experience will be with those 3 therapeutic drug classes. So I think at this point we're recommending about 2.5 million in savings, which is not huge. If we expanded it more in the future, it would be a lot more savings, but we want to make sure that we get our feet underneath us and that we have the procedures with our call centers, prior authorizations, all the things that are necessary before we expand it even further. So we believe that the therapeutic drug class with the 3 is a pilot before we actually do a full solicitation beyond that.
Okay. Ms. Donaldson?
Good afternoon, Mr. Chair, members of the committee, Kathy Donaldson and Dr. Richardson, CalPERS team members. This is agenda item 7A, an information update on reference pricing prescription drugs by therapeutic class. This is a program that we have done extensive research by our team, as well as 3 presentations to you that discussed ways to lower and stabilize CalPERS over $2 billion in prescription drug costs. And you'll also note that you have an information consent item that discusses the annual spend that we are presenting, and it shows that in agenda item 5C, in 2017, total drug costs paid under the pharmacy benefits program was $1.25 billion, a $223 million increase from 2013. I want to just remind the committee about how we came to these therapeutic classes, because we have spent really over 4 years looking at this as an option, and even worked with CVS to see if we couldn't implement when they held our contract. And while the classes and the savings are important, There are also patient safety considerations. And then as Mr. LaFaso pointed out in one of our committee meetings, it's not just the therapeutic class, it's also the subclasses which describe how a drug is going to be administered. For example, while corticosteroids showed up as one of the top 10 classes, corticosteroids are quite a number of different types of drugs, delivery systems, creams, patches, injections. And so it's really the subclasses that we have presented to you as part of this pilot, the nasocorticosteroids, the oral estrogens, as examples. And so while we talk about the therapeutic classes, those are really a higher level classification. What we are presenting are the subclasses. The other part of running a reference pricing program that showed up as part of our research is patient safety. That is, we can say that this is a good drug to maybe reference price, but if it's in the class of antipsychotics, it might not be good. And so we could save quite a bit of money if we wanted to reference price the antipsychotics. We could save a lot of money if we wanted to reference price all diabetic drugs, regardless of whether the pancreas is producing insulin or not, whether a member was insulin dependent and would die without it. So there's a lot to consider when looking at reference pricing drugs by therapeutic class that do involve the PBM's Pharmacy and Therapeutics Committee. And so those are things I don't think we spelled out in our discussions with you that I want you to consider. We did look at 70 classes with UC Berkeley, and we could save $34 million, but that's sort of a wholesale approach to really savings versus value. Savings, safety, quality, evidence. So with that, I will just remind the committee about what we have done to date, and then I'm going to turn it over to Dr. Sun. So our program does begin, and we called it a pilot. It's for lack of a better descriptive term, and it is the 3 therapeutic drug classes that we presented to you. And it is those classes are administered through our claims system by our Pharmacy Benefit Management company. And we've designed this so that it's more transparent to you what you're actually spending money on. Because if you just say generic preferred brand, non-preferred brand, there's not a lot of transparency around what you're paying for. In June, you did direct us to include another vendor, but it was really primarily for the customer service portion as we interpreted our directions. It was more for a customer service outreach, including provider education. And that is an area of focus for us this year, is not just provider education on our formulary or our reference pricing program, but on opiates as well. So we are launched in 2019, beginning now, a really strong approach to outreach to our prescribing physicians. So those are some of the considerations that I want you to think about in terms of the customer-facing focus for this second vendor that we were directed to look at. And with that, I'm going to turn it over to Dr. Sun and have him continue the presentation.
Richard Sun, CalPERS medical consultant for a few more days. To implement the committee's direction, team members first noted that the participation of the PBM is critical. In general, in collaboration with CalPERS, a PBM's tasks in reference pricing would include establishing the therapeutic drug lists, and as stated in previous agenda items, we've already decided on the initial 3 therapeutic classes, programming the claims processing and adjudication system, developing marketing and communication materials for members, providers, and pharmacies, and finally, implementing and managing the program. For example, the PBM, with assistance from its Pharmacy and Therapeutics Committee, is expected to monitor the therapeutic drug class lists on a regular basis. Next slide. However, involving a third-party vendor required a division of labor among the PBM, the vendor, and CalPERS. The current concept is that the vendor would be assisting with certain aspects of the program: marketing, member support, clinical support, and ongoing program evaluation and quality assurance, Please see attachment 2 for details. Next slide. Member communication and customer service are very important to the administration of the program. Customer-facing support, which will involve the PBM, the vendor, and CalPERS, will include interacting with members, pharmacies, and prescribers face-to-face, online, and via phone. Next slide. To get to this point, the CalPERS team analyzed 4 different approaches to administering the program, whose advantages and disadvantages are summarized on page 3 of the memo. Number 1, administration by the PBM only. Number 2, by the PBM and a nonprofit governmental entity. 3, by the PBM and a for-profit entity. And finally, to hold a solicitation that would lead to a direct contract between CalPERS and a vendor. As we balanced the considerations and considered the committee direction, we decided to go forward with option 2. The PBM recommended that the reference pricing program involve the University of Massachusetts, a nonprofit governmental entity, and CalPERS accepted the recommendation. As noted in the agenda item memo, this option allows launching of the program in 2019. Other options would have delayed the program. A solicitation would potentially divert team resources away from the current PPO solicitation. And now Dr. Donaldson will summarize next steps.
Thank you, Dr. Sun. I wanted to point out that's the University of Massachusetts School of Medicine, who has an independent arm that manages programs for customer outreach such as this. It is our plan to move forward with implementing the reference pricing program for pharmaceuticals using the option of another vendor being the University of Massachusetts School of Medicine. We will work closely with the PBM and this entity to deliver comprehensive engagement and communication activities to deliver superior service to our members, doctors, and pharmacies. We will update you on the progress of the program in 2019, and we will continue researching additional solutions to stay ahead of increasing drug pricing. Thank you. That concludes our presentation, and we're available to take questions.
Thank you. We do have one request from the public to speak, but is there any questions on the board? Ms. Mother, please.
Yeah, I just have, forgive me for if you've shared this and I am not remembering, but could you remind me, so we do a pilot with these 3 therapeutic subclasses, as you've identified. How long will the duration of the pilot be, and what's the process for evaluating and then either expanding either solidifying the program as a program and no longer a pilot, or expanding it to other therapeutic subclasses?
One of the questions that has been asked of us many times when we bring forward innovations is, what is your measure of success?
Yeah.
How will you evaluate it? How do you declare success? And I thank many of the committee members who continually to ask us these questions. So we do have a research arm of our branch under Dr. David Cowling. He has research scientists. He's worked directly with University of California, other academic institutions, and he is working directly with Berkeley on this. And so he has already thought about how to evaluate this pilot. One of the reasons we want to start small is disruption. We just want to be very careful in terms of our membership, and that's really why we were beefing up more of the customer service end of this pilot. So we do have ways in which we plan to evaluate this pilot. We would report back to you in a year our progress. And then at that point, we could make a report on where we are in terms of reference pricing. So that's kind of our plan. Give a year, see how it works. Let us work out the kinks with our members, because our members, these pharmaceuticals are very important to our members. So we want to work out those kinks. We do want to see if it'll eliminate member pays the difference. We do want to see if it reduces high-performance generic step therapy or eliminates it. We do want to see if utilization management can be streamlined. Those are sort of the goals of the pilot. As Leanna pointed out, it's not so much to save money, although we don't want to not have some savings. It's really about, can we do this on a small scale before scaling it up to a large set of classifications of therapeutic classes? When we looked at even the top 10, the diabetes drugs were showing up. The antipsychotics, which treat bipolar disorder, which treat schizophrenia, which treat depression, we just have to be, in my opinion, for safety reasons, very careful with not just classes of drugs, but what subclasses. There are some on this list of 70 we may never want, from a patient safety perspective, to reference price. So that's kind of our time frame. We would report back in a year. If we felt that it was successful, even though hips and knees took like 5 years before we reported back on its success, we probably could come back with a fairly, with an idea of how much it would work, and perhaps then start carefully adding more classes.
Okay, thank you very much.
Ms. Holton Hodson?
Thank you.
You're on.
You could turn
You're
on
on.
my mic. I think we are excited to see how this turns out. Certainly big supporters of members pays the difference. I guess a couple of questions. One is, what is UMass's experience with reference pricing, particularly when it comes to sort of customer service and serving a population like ours? I know there's sort of a limited pool of experts in this area. And also, if you could speak to sort of Optum's experience in this area, and how have they done reference pricing? Do they do it themselves? Have they partnered? Who have they partnered with? So if you could just sort of go into those two issues, I'd appreciate it.
I'm going to answer the second question first, and then have Dr. Sun address the first question second.
Okay.
Yes, OptumRx has has done reference pricing for other clients, and so it operates very much the way Envision Rx, which is now out of business. They sold to Rite Aid. It's very much structured the way Envision did it as well, and that is, they come up with the list for the reference prices, sometimes themselves or in concert with a second party. So sometimes the second party who's contracted, say, with a health plan recommends the list, then it goes over to the PBM, who then has to take that list and run it through his pharmacy and therapeutics committee, again, looking for safety, looking for sometimes the classes of drugs are small. You may not get as much return, or maybe it's just not a good class to reference price. So even though you can have a PBM plus a second party working together, the PBMs today are moving in this direction. And not only are value-based purchasing or reference pricing pharmaceuticals by therapeutic class is moving forward. It's moving forward with the other two PBMs. Sometimes with a second party, sometimes they're thinking of it on their own. I will tell you that specialty drugs and reference pricing specialty drugs is the next frontier for the pharmacy industry, as the PBMs administer specialty drugs. So it is a movement that all PBMs are doing now, but there's probably going to be, you'll probably see within the next 2 or 3 years that it's expanded, not just to the non-specialty drugs, but to the specialty drugs as well.
And so could I just add on to that? Is there a reason we just didn't ask Optum to go through its usual process with its usual second party to do this instead of choosing UMass and, again, speak to the experience of UMass?
Well, Optum could do the whole, as any PBM in this day and age can do. They can do it themselves, but we were looking at more of the customer focus because that's where we get so much friction. But that doesn't mean that we can't continue to explore other relationships or other activities that make it more efficient.
Thank you.
To our knowledge, in previous efforts in reference pricing, OptumRx has not had a direct contract with a subcontractor for reference pricing work. Now, about the division of labor, in Attachment 2, CalPERS and OptumRx went back and forth about which tasks the vendor would be able to do, the vendor being University of Massachusetts. UMass has not participated in a reference pricing program previously, yet they have numerous projects in the pharmacy space, and so they are able to do they're able to help with marketing to members, pharmacies, physician, member service support, clinical, financial analysis support, and so forth.
So if they haven't done this previously, why are we picking them versus vendors that are more experienced in doing it?
So part of it is it's broken up. So there are third-party analytics that actually run your data through their tool. And then when they mine their tool, they will tell you what your subclasses of information and your savings and how to administer it. So there's that piece of it. There's the PBM that does the claims and the adjudication. And in this case, what we were looking at is we had already worked with University of Berkeley, who had all of our subset, and we came up with the 3 drug classes working with them. And then as such, all we've asked of OptumRx and then University of Massachusetts is to basically work together to ensure that our members experience a prior authorization, the things that are on the list of what attachment is that, attachment 2, is outlined, and those were the requirements that we had made of OptumRx. They proposed who they wanted to sub with, and contractually we have the authority to approve or deny, but we do not have the authority to tell OptumRx who to subcontract with.
Thank you.
Mr. Jones.
Thank you.
Just a second, Henry. Push your button. There you go.
It's pushed.
Sorry. No, I don't.
Okay, thank you, Mr. Chair. Yeah, 2 questions. One is, did you go through an outreach program with the stakeholders and retirees about this program coming forward when you first presented it several months ago at this? That's the first question.
Yes, we've done many outreaches with the stakeholders on this topic.
Okay. And then the second question is that I appreciate the tool set where you talked about evaluating the program and reporting back and getting information on the progress. But I think also many times the sample size could, in terms of a pilot, could be small. Then when you get ready to roll it out and there's a large group implications, it doesn't seem sometime to work out the way. So I would suggest you also, when you roll out a new program like that, based on a small sample size or a pilot, there'll be an exit strategy included in your implementation program, okay? Yeah, because we've had programs before that when we implemented them, they didn't work out as we planned, and then we were scurrying around trying to find out how to get out of it. So I would suggest we do that as part of a going
I think that is an excellent idea, and that would be part, I think, of the evaluation study. That with the evaluation study, we'll set the parameters up front, launch the pilot. The upfront parameters would also include what worked, or if it worked or didn't work, and then the exit strategy.
Ms. Taylor?
Yes, thank you, Mr. Chair. So, what are the other 2 PBMs that you were talking about?
Express Scripts and CVS.
Okay, and as I understand it, CVS hasn't started this. They're going to, but they have not.
There is that correct, Richard? They've actually announced publicly. Oh, okay.
So, and then you guys talked about UC Berkeley and Optum working together to do what exactly for this?
So originally what we did is we worked with UC Berkeley. We provided them a copy of all of our claims data. They mined it. They worked through the research, and they helped us come up with what 3 therapeutic subclasses we should be looking at. The state staff, Melissa Montong and Dr. Sun, were the ones that mainly made that recommendation. Based on that, working with Optum, we want them to implement this from a PBM perspective, because the medical claims and adjudication you cannot do this without the PBM. It's very clear. And then what we asked, based on board direction, is even though Optum said they could do it, board direction as of June said, please consider including another vendor. And so what we wanted to make sure is that University of Massachusetts has done pharmacy type plans with, maybe Dr. Sun, you can explain, because I know you have the requirements, but they've actually done a lot with other states regarding working with PBMs.
That's correct.
Okay, so Optum actually didn't bring this to you. You went to the UC Berkeley to talk to them about it?
So we actually, when we were with CVS Caremark, we've actually been thinking of this for a while. 2015, when we worked with OptumRx, there actually is a line item in our contract in order to implement this. So it was actually built into the contract with that in mind.
But they didn't go out and you know, look at this themselves and bring it back to us. We had to bring it to them.
We brought it to them. Kathy and the team have been pushing to move this innovation forward, but they were not the ones that established the subclass. That was our work with UC Berkeley and Mr. Jamie Robbins. So.
And then we brought, so when we asked for more vendors, then you brought in UMass, but they haven't ever done reference pricing, just other stuff with pharmacies, correct?
That's correct.
Okay, so do they have a population similar to our population that they've done? I mean, we've got, what, 1.4, 1.6 million people.
I do not recall the number of lives that they have worked with, but it's substantial. I do not know if we added up the number, I don't know the
We
sum.
probably should get that, because it would seem to me that if they're the ones that are going to be working with us, and we have another vendor that we've talked about before that has worked with several 100,000 up to almost 1 million members already, and they've done reference pricing, and this, I'm just concerned now, I didn't hear this before, that UMass had not done reference pricing. I was led to believe they had done reference pricing. So I'm a little concerned now that we're at this point of consideration, but UMass hasn't done that. So it is, in my opinion, that we don't do this right now until we have more information.
I would like to provide some information, as you requested. The University of Massachusetts School of Medicine consults with 28 states in the United States, and they do a variety of different services in the pharmacy space. They also do consulting in the medical space, but this is about pharmacy. They do utilization management reviews. They do client advisory outreach to providers, to physicians, to prescribers. We have seen the extensive list of services that they offer. Reference pricing is a very narrow part of pharmacy benefits management. It really, what it does is it says, here's your brand price, here's your generic price, here's your lowest cost alternative within a class. If the member selects the lowest cost alternative, even if it's below the copay, they get the lowest cost alternative for that price. So that is really the crux of reference pricing. It has to be done through a claims adjudication system. You can bring in secondary vendors that say, okay, we took your data, and we have to give them the data. We took your data, we ran it through, and these are the classes we recommend. Unfortunately, formularies change, and so you're doing that. You could be doing it every day, but we don't choose to, but you could do it every quarter. So periodically, we have to provide to a secondary vendor our data so that they can make recommendations on the classes and make recommendations on the savings. It is a guide for a purchaser, and we appreciate that.
So does Optum?
Ms. Taylor's microphone, please.
I'm sorry. I thought Pam did it.
There you go.
Does Optum have that ability to do that? Run it through the pharmacy?
Yes, they do, and they have clients, other clients that they're reference pricing for.
Okay, so they do?
OptumRx does, yes.
OptumRx is already doing reference pricing?
Yes.
Okay. And they do the adjudication
Yes.
themselves already?
Yes.
So what's the And UMass does it too? I'm confused.
UMass does not reference price, but they provide sort of a holistic shell around reference pricing. The outreach, the utilization management reviews, the academic detailing to the physicians, the outreach to the pharmacy. They actually run customer call centers, so we looked at because we were looking at front-end customer service, we were really looking at them for synergies around more customer outreach so that our members get a higher touch in terms of the pharmacy benefits program.
If you look at attachment 2 under claim system setup, the vendor
looking at
column
it
is
right
blank. And that's because we do not foresee the vendor having any role in claims adjudication.
Okay, so what is the purpose of UMass? I'm confused. So they don't do reference pricing and they're not going to? It's going to be Optum Rx.
The purpose of UMass is to respond to the committee's direction.
Pardon me? Okay. I'm lost.
Anybody else from the board before we go to the audience? Mr. LaFaso, please.
Thank you, Mr. Chairman. Just to circle back, if I understand correctly, when we're talking about reference pricing, the key issue is what the reference is. And in the medical procedure context, that's very different than the pharmacy context. What I'm understanding you saying is that the role of UMass is to provide the pharmacy expertise so that the references and the reference pricing in this pharmacy context are appropriate to a pharmacy context, and the focus is on pharmacy, more on reference pricing. Am I correct?
That's correct.
Thank you.
Ms. Mother, please.
You're on.
I'm sorry. I thought now I'm confused. I thought that the purpose of having a vendor was really to another form of assurance that the experience that's being reported, just to give us more confidence in the data and the analysis of the data that we were receiving from the PBM.
So that's correct. So referring back to attachment 2, they will be providing the clinical and financial analysis support. So you'll see where the check marks is where they are responsible. Obviously, CalPERS is not giving up its responsibility, but they are supposed to be adding a value for their participation.
Yeah.
The piece was is we've already established a therapeutic class. The PBM is the engine that runs all the claim information. It's also, we want to make sure that for these 3 drug classes, our members don't have a different member experience or customer service number that they have to call. It needs to run through the same process that they're used to with the PBM. It should all be very transparent to them. But one of the things that the U of Mass is going to provide the value out of is basically in developing draft candidate drug classes for inclusion in program. They will be doing a therapeutic committee, essential drug class review. I mean, there's reporting, there's things that are actually, that sit on top of the PBM. So they are kind of like, I think Kathy was saying, the shell that kind of pulls it all together. If we were establishing from the very beginning the therapeutic drug classes, we would need a very different vendor. But since we've already established that and spent this last year with Jamie Robinson, we're already there.
We've
we just
already
need someone to take
selected the
us.
therapeutic subclasses.
Exactly.
We don't actually need such expertise in how reference pricing works in the pharmaceutical context.
Correct. But when we're ready to expand, let's just say, let's just say we're successful, we will need a third party to look at everything and decide what's the next course, which is potentially where a lot more savings will happen. But we'll have the member experience behind us in order to make that decision.
Okay, thank you, that's helpful.
Any other questions from the committee? Seeing none. Mr. Henke, please come down. You'll have up to 3 minutes. Please identify yourself for the record. It's on.
Mr. Chair, members of the committee, David Henke. I'm the president and CEO of Active Radar, which is an analytics and technology company that specializes in reference pricing. We have a technology platform that works. We've worked out the kinks. We're a member and customer communications expert. In our experience, a pilot is really not necessary for this type of program. The data, in many respects, speaks for itself. We would recommend working with staff and select a number of therapeutic categories, whether that be 3, 6, 9, to identify where the cost savings is. Our platform is able to identify down to the belly button level how many people are impacted and what the expected cost savings will be for CalPERS. We also have built into our platform the analytics and reporting capabilities to share with staff and with the committee and with the board on a regular basis what the impact to members is and what the cost savings is, and we could set up the metrics on that on a monthly, quarterly, or biannual basis. Our recommendations would be to start off with a select number of therapeutic categories, review it not on an annual basis, but on a much more frequent basis to determine what the member experience is and what the member impact is. Our platform and our experience in this field is over 8 years. We are the leading experts in this area and have worked very closely with the University of California at Berkeley. Our work was featured in their research that was published in the New England Journal of Medicine this past year. So I believe that we have the expertise and the experience. In addition to that, our platform has been integrated with OptumRx on numerous occasions. We're a California-based company, and we have hundreds of thousands of members already on the platform with Optum as a PBM in California. Our program includes pharmacy, provider, and member outreach as part of our package that's already built in. It's been tested. It's been vetted. The devil is in the details with any type of technology platform, and our platform has been a proven success in this marketplace.
Thank you.
Thank you.
Any other questions or comments from the committee? Ms. Mother.
Thank you, Mr. Chair. You know, you started out this item asking the question as to whether this needed to be a pilot or whether a full solicitation really is appropriate. And I'm still left with that question and not feeling fully satisfied on that question. And so I'm wondering if it would be appropriate to ask staff, I know that this is, we've brought this item back a few times, but to ask staff to come back to review that a little bit more fully. What would a full solicitation look like? Because I think this is being called a pilot, but usually a pilot is really around having a smaller population testing an idea. This is really having our entire population and just first rolling it out to 3 therapeutic subclasses with the possibility of rolling it out to further therapeutic subclasses, again, for the entire population. So the use of the word pilot, I'm not sure, it's really sort of our first step into this world of reference pricing in pharmaceuticals. And I share your question as to whether it needs to be called a pilot or whether just launching it and doing a full solicitation with some options for expansion further out might be more appropriate. Or exits.
Great.
Yeah.
Thank you. Ms. Bailey-Crimmins. Good luck. There you go.
Oh, there we go. I would just like to point out to the board, we're in the middle of a PPO solicitation, so if there was a solicitation, it would not be until after rates, which we would be bringing that back to April. So we would not see a full solicitation actually hit the street till June or July of next year, and it would delay potentially any savings for a year to potentially a year and a half. Just wanted to make sure you're aware of that.
But you could also take the information that I brought forward and Ms. Mother did and come back in November and give us a better idea of where we can go from there, correct?
Absolutely. Yes, sir.
Okay. That'll be the direction then. All right. Oh, Mr. Miller, sorry.
Sure.
Just a second. There you go.
Just want to make sure I understand. So if I understood correctly, CalPERS didn't choose UMass, Optum chose them, and we basically assented to their choosing UMass for that kind of overlay of what they're doing. But if CalPERS had had the option, we might have chosen someone different, say Berkeley or someone.
So in June, when we gave the recommendation, it was Optum, and then based on board direction, we were told to bring on another vendor. But Kathy pointed out at that time, the PBM is the workhorse. It is the engine that requires this. And so the only way we could do this is actually through a subcontracting relationship with our current prime PBM. And so what we did is we explained to Optum Rx what our requirements were. We had already established a therapeutic drug class, so what we needed was a complement to Optum in order to make the pilot successful. And as such, way our contracting rules are is that we cannot tell our prime who to subcontract with, because I'm holding that prime accountable for contractual performance measures, so I don't want to get between them and their contracting relationship. And so what they did was, based on our requirements, they gave us a presentation, and we have the authority to approve or deny anyone they bring in front of us. We just can't tell them who to work with. And so when we received the presentation from University of Massachusetts, it seemed like they were able to add the complement of expertise that we felt like we needed in order to proceed.
All right, thank you. Seeing nothing else on this item. 7B, evaluation of health regions for public agencies and schools. Ms. Little.
Good afternoon, Mr. Chair.
Not yet.
That one.
Let's try this
There you go.
again. Good afternoon, Mr. Chair and members. Sherry Little, CalPERS team member. Today we're here to talk about Agenda Item 7B and to continue our discussion around healthcare regions for public agencies. I know that CalPERS, as you well remember, CalPERS regions were first created in 2004 as a result to maintain and retain our contracting member agencies. We risked losing some employers, and the board decided to create some regions so that we could be competitive and go out and retain what we had currently in place and gain more public agencies and schools, as they represent currently 41% of our total book, or around 600,000 total covered lives. Today's presentation is an information item, so I'd like to begin by sharing the results of our employee survey and some of our outreach activities with our stakeholders. I'll also talk to you a little bit about the methodology in preparing the analytics, and we'll show you the first subset of the data that shows the relative costs of health care by county for public agencies and schools as it compares to the statewide average. And finally, I will preview for you what we are planning to do in November and December at our board meetings. This is the third presentation in our series. At the July offsite, if you'll recall, we talked about the history, the background, and some of the challenges that we've faced. Milliman also talked about their methodology using the CalPERS data and how regions were first established in 2004, and provided a market analysis and scan. The slide you see before you right now was also presented by Milliman at the July offsite. We thought it'd be a helpful reminder to visually show you the concentration of agency and school membership right now. The left-hand side represents the employers, and the right-hand side represents the employees by county. So when we were looking at this, we wanted to think about the best way to take a comprehensive approach so we could get to the right decision. So we incorporated both qualitative and quantitative approach in gathering data and information. The process include working with employers and our stakeholder groups and getting their feedback and their concerns and insights into the process. The team also completed a significant amount of work to date, and I want to remind you we're still going through all of the data that we have. It's been quite a while since we revisited it, but we want to make sure that we bring you the appropriate, answer the right decisions, bring you the appropriate data, give you right decisions to make some decisions around regions, the regional factors, the nomenclature, and all of that moving forward for the 2020 year. We also wanted to make sure that both employers and stakeholders had a voice in the discussion and were able to share their insights and their ideas. So to that end, we conducted survey with our health contracting employers. We also had an educational webinar called Your Guide to Health Regions. It was the first one for me. I think it was the first one for a lot of people on our team. And we covered the history and addressed primary questions that we had been hearing from our employers. If you haven't had a chance, I'd encourage you to take a look on the CalPERS YouTube channel. And we were able to get some really positive feedback from our stakeholder groups. I think CSAC said it was the best webinar they'd ever seen, which was kind of nice, refreshing to have nice feedback. We also had 3 additional focus groups. We met with our retirees, the labor folks, as well as the employer associations. So I'd like to just take a minute to walk through some of the highlights of that feedback. Between July 29th and June 29th, and July 20th, we surveyed our CalPERS health employees. We received about 260 responses across all of our different regions. And just to give you some of the general observations, over half the employers that we talked to said that our premiums were moderately competitive in the marketplace, and over a third said that we were extremely competitive in the marketplace. That data point indicates that how competitive our rates are in the market, which is important as we continue to try to attract more public agencies, but also retain the ones that we have existing. There were a few consistent themes we also heard in our outreach. We heard concerns from the Bay Area and other Northern California region employers about premium costs, as well as the naming conventions. Very simply, employers don't quite understand why they're called the Bay Area if they're not geographically located in the Bay Area. We had consensus from all the stakeholders that at a minimum, regardless of what we do moving forward, we may want to reconsider that factor. And maybe think about renaming to something like zones or colors or shapes. We heard all kinds of things around that. And during the focus groups, when we asked stakeholders if they were open to the concept of splitting up counties into zip codes, they liked that approach. They wanted to take a look and see where that led. So we've been collecting some 3-digit zip codes that we'll be bringing back to you in November. And beyond that feedback, we heard about a lot of other things that were not regionally related, but we received feedback as we always would with stakeholders. So moving to the analytics, I just wanted to go over a couple of things first. I wanted to talk a little bit about the methodology that Milliman and the team used and the information used as the basis for the analysis. For the methodology, the team used millions of healthcare claims records for a 5-year period between 2013 and 2017 from the CalPERS data warehouse. That data was summarized and grouped by plan for the differences in payment structure, in benefit design, and in the networks. Our methodology combined both PPO and non-Kaiser HMO to calculate the relative cost of care over the 5-year period. Kaiser HMO was not factored into this and will be considered separately when we meet with you in November because, as you know, it's a 2-region model, North and South. For the basis of the analysis, I wanted to refer you to attachment 3. It's called Cost Relativities by Current Region and County, and I think it gives a good snapshot. It's a table that shows the relativity for each county ranked by the cost. The relativity was calculated based on each county's healthcare costs and adjusted for health status. To account for the outliers, such as high-cost claims or counties that had low membership, we excluded them at this pass. Those counties are Modoc, Sierra, Alpine, Mariposa, and Kings. And using this methodology, the county with the highest cost, you'll see, is Siskiyou, with a relative cost of 1.41, and the lowest is San Bernardino with 0.77. So basically what that means is Siskiyou is paying 41% higher rate than the state average, and San Bernardino is paying a 23% lower rate than the statewide average. And moving to attachment 1 of your agenda, this is a visual representation of the data that you just saw in the table. You'll see the counties higher than the statewide average, illustrated in variations of red and blue. The red are higher, obviously, and the blue are lower. And you'll also notice some gray counties, and those were the ones that had low membership and had insufficient data to calculate a credible cost. This is one way of looking at the data, but it's really like to caution that we can't just use the red and blue to carve out regions. Our analysis between now and November will take into consideration this, along with the 3-digit zip codes and the Kaiser HMO, and overall impact to employers and employees. So to summarize the region analytics, I want to call your attention now to attachment 4. This is a scatter plot view that shows the relative cost of care for each county within the CalPERS regions. Please note that this one's revised. I hope you just received a handout of the new revised scatter plot, and there are also additional copies in the back of the room for everyone in the audience. Because of the way scatter plots are developed, the first version didn't quite capture. It was hard to see some of the counties, so we revised it and wanted to give you a more clearly defined one. As expected, you'll see a variation across statewide. And not surprisingly, you'll see that the high-cost areas are spread from Northern California to Central California. Also want to note that there's a slight update to this slide that's supported by the data. There are 40 counties above the state average, and roughly represent about 53% of our total covered lives, and 13 below the average that represent about 47% of our total covered lives. So moving forward, as we analyze the data, we will develop and assess scenarios based on some fundamental principles, which we discuss with the stakeholders as well. One, and the most obvious, is that we want to remain competitive in the healthcare market. This was really the impetus for creating regions in the first place, and it still holds true. Being competitive allows us to win and retain what we have currently in place and to grow our total covered lives. That gives us better leverage. It's also important that regions provide the greatest benefit for the greatest number of people. That's the theme that not only we believe, but was echoed repeatedly by our stakeholders. And of course, we must be PEMCA compliant, since that's the law that governs our program. Looking ahead between now and November, the team's going to use the relative costs of healthcare and the stakeholder feedback we've received to shape and bring you scenarios. And with each scenario we present, we're going to show you how that would have impacted the 2019 premiums, to give you a good idea of how employers and members would have been affected by each scenario. And take that as it's compared to the market. All this will be done, and we will continue to do some stakeholder outreach at Ed Forum. And the culmination of all of these presentations and that data is really intended to provide you the best information you need to make a couple of decisions. Those 2 decisions will be about regions, or regional or zone boundaries, how we draw them, and the subset of that being the nomenclature, how we name them. And the second will be regional factors for HMOs, which will ask for direction on how to be determined. We could keep them as they are currently. We can also develop a range that's acceptable, or CalPERS can just set regional factors. In November, you'll see the full set of data, and the scenarios for your consideration. And it should give you a little bit of time to ask questions and contemplate that. And then in the December meeting, we're going to ask for a recommendation and see what your thoughts are about that for the 2020 health plan year. And with that, I will conclude my report and offer an opportunity to ask questions.
Thank you. Anybody have any questions or comments at this time? Ms. Mothra.
Thank you. I just want to say that I think this is a really good start to this work. It's important that we're doing this work now. I think we've heard, as you've heard from many employers, I think that's a good sign that more than a quarter of the employers actually responded. That I think that's excellent, and I really appreciate the direction that we're going in to be very thoughtful and evidence-based, data-based around how to advance or continue with the region. So I want to thank you all for the work that you've put in so far, and look forward to seeing your first cut in November.
Thank you.
Thanks.
Thank you. Anyone else? Mr. LaFaso.
Thank you, Mr. Chair. I think the stakeholder process here is looking really good. Just so it's pretty obvious that the data is pretty instructive in terms of saying that while north and south are pretty clearly differential, maybe urban and rural aren't so clearly differential. Given how challenging it is to do these regions, I'm wondering, does staff think that the relationships in the table that you put in our packet, the one that shows that Siskiyou is the highest and Inyo is the highest, that is fluid over time? Or do we think these relationships in terms of this county versus that county are generally fixed over time? The point of the question is, are you looking to design a system that allows you to account for changes in the cost relationships over time, or do you have to go to a whole new process every time you want to adjust the geographic areas based on changes over time?
So I believe that they are fixed for a period of time, but what I would say is what we recommended is at least every 5 years to bring back an analysis to the committee. Our stakeholders, actually employers are recommending every 3 years, but it's a pretty heavy lift to bring this much data to all of you to consider redrawing any lines that often. But I would say as hospitals and providers grow, as more Northern California moves away from fee-for-service, if I have my wish list and move more towards capitation, you might have better contracts. It might actually reduce the overall cost. I think they're fixed for a period of time, but hopefully the market starts to drive where they are becoming more competitive and the cost may vary. So I wouldn't want to say that this is the way it would look like in the next 10 years. I would say we owe it to you to bring that thoughtful, the data like Ms. Mothra had mentioned, we owe that to you to see at any point in time, do we need to make a change?
Appreciate it. Thank you. Thank you, Mr. Chairman.
Right. Thank you. Seeing no other requests, thank you. We'll see you in November. On to item 7C, open enrollment app.
When we talk about live demo, it's live. It's actually connected to the phone.
All right. Good afternoon, committee chair, members of the committee, and other board members. Rob Derzambet, CalPERS team member. Presenting with me today is CalPERS team member Tim Taylor. As Leanna mentioned earlier, this year we developed a new mobile app for open enrollment, which debuted on August 27th. The goal was to enhance access to health plan information and provide it in a way that members have requested. So to do this, we reached out to IT to see if they could assist. This turned out to be a great partnership, and I'd like to publicly recognize key contributors who rose to the challenge to create a unique mobile experience for our members. They are David Krasny, Paul Buknovsky, Mike Moltzen, and Marilyn Clark. I'll turn it over to Tim to explain what his team did.
Good afternoon, Tim Taylor, CalPERS team member. I just want to echo Rob's sentiments in regards to the project. Great partnership between program and IT. I have to commend Rob's team as well as the Office of Public Affairs, who contributed greatly in this very quick activity that we were tasked to do, but successful. I just wanted to point out that it's our first foray into mobile application development for CalPERS. It was I would say, a mildly unanticipated request, but a great opportunity, and we seized the opportunity to rise to the challenge. We leveraged the existing CalPERS system and the development of the system, so it's really important to note that the primary system was leveraged. We're using a lot of those components, and we're just able to build a complementary mobile application that interfaces with it, and that allows members the convenience of either interacting with the system from their desktop computer or from their mobile and having a seamless transition between those two. So again, a big thanks to our partners. We really appreciate the opportunity. It was fun.
All right, thank you, Tim. The mobile experience can be accessed by members watching at home or here in the auditorium by going to mobile.my.calpers.ca.gov on their smartphone or tablet. The app allows members to use their mobile devices to access their MyCalPERS account, where they can search and compare medical plans, view any custom messages they may have, and retirees can make a health plan change and also add or remove a dependent. So first and foremost, the mobile experience is secure. The OE app integrates with the existing MyCalPERS identity management solution to keep our standard for security and reliability. Members who don't already have a MyCalPERS account can register through the app or reset their password if they've forgotten it. So let's take a look at the app. So for this demo, we're in a test environment using a fictitious member. Jane Doe is a state retiree currently enrolled in the PERS Choice Basic Plan. After a member logs in, they're taken to this homepage where they can view messages just for them, look at information about their current medical plan, see information on about the subscriber as well as any dependents, and also view any future transactions. So first, let's look at the message in their account. So I'll select, you have one message, and this is one of the custom messages we have this year. So for this member who's enrolled in the PERS Choice Basic Plan, we want to inform that group that their copays are changing for 2019. This is just one of over 20 specialized custom messages we've created to help inform members about key changes that are happening to their health plans should they decide to remain with that health plan in the next plan year. Going back to the home page, the next feature to check out is the Compare tool, or Explore Plan Options. So because we're in the members are logged into their own account, the search criteria pre-populates with their information. So information such as their eligibility zip code, we know what member type they are, whether they're state, CSU, or public agency or school, and we also know what coverage type they're in, whether it's basic, combo, or Medicare. A member can modify this information or proceed with the comparison. So based on the information we've entered, here is what the results show. So their current health plan shows first. So this shows the member share, what the member would pay out of pocket, the employer share, as well as the total premium. So for this member, she has 9 other health plans available to her. So for this comparison, let's compare the PPOs. So we'll compare PERS Choice, and then scroll down to find PERS Select, as well as PERS Care, and select Compare. So by doing this, you see the out-of-pocket member cost up at the top, as well as a variety of other information, such as a calendar year deductible, the maximum calendar year copay and coinsurance, and a variety of other information. So the members can then scroll from left to right to look at all the different plans that they've selected to compare. Members can also save this comparison by selecting Save, and it's saved to their account. So they can view any saved comparisons without having to walk through these steps by selecting the Saved button, and they can also pick up where they left off if they choose to log in back at home on their computers, because it's all in the same MyCalPERS account. So now after we've compared the plans, let's make a plan change. So to do that, we would select Change down at the bottom, and it gives a list of the things that we would like, we're able to do via the app. So first we'll change. So it asks about association information, which will continue. To do this, we really want to make sure the members are really informed and using the correct information. So although it pre-populates, we want them to acknowledge this. So we'll continue with this. It gives them information about their current plan and what would happen if they choose to stay with that plan for the next plan year. We're going to explore plan options, which is the exact same thing that we just did when we did the compare feature. And so we'll be selecting PERS Select because that has a 0 out-of-pocket cost for the member. Select Continue. It'll ask you to confirm that. Oops. And then, are you sure? Yes, we're sure. And the medical plan has been updated. So it's that easy and simple for a retired member to make that change via their smartphone or tablet. Lastly, let's look at adding a dependent. So we'll go back to the home screen. And so for this demo, Jane is going to add her spouse, John, to her health plan. So we've already added John's information, and that appears here. So to move ahead, I want to take advantage, I want to show how this app can take advantage of the abilities the phone has. So when you're adding a dependent, you need to provide certain documentation. So for a spouse, it's a marriage certificate. So it calls that out here. So it says the documents that we need. And then it takes advantage of the camera feature on your phone to quickly and easily take a picture of the marriage certificate, use the photo, and then submit it to CalPERS. So this is a very easy and convenient and secure way to get that document to us in a matter of seconds. This saves the member time from having to upload that marriage certificate to their home computer and then upload it to their account in my CalPERS, also having to make a copy of it and mail it in. It goes through the mail, then the mailroom, then finally makes its way to a CalPERS team member to process. So this brings it to the CalPERS team member in a matter of seconds so that they can process it more timely. So this mobile experience will be available through the end of open enrollment, which is October 5th. So far, we're happy to report that over 10,000 unique members have logged onto the app to access their information. 44% of that population has been retirees, and that falls right in line with our general subscriber population. We've also had nearly 150 plan changes made via the app alone, and 2 retirees have either added or removed a dependent. To gauge customer satisfaction, each week we are emailing a survey to members who have used the app. It's a quick survey which aims to gain feedback on the ease of navigation, the information available, and their overall satisfaction with the mobile experience. As of mid-September, we have an 88% overall satisfaction rating with the app. We're always looking for ways to improve our communications and the customer experience, so the feedback will be helpful in identifying those opportunities, as well as helping inform us on where we go next with our mobile experience. This concludes our presentation, and we're happy to answer any questions.
Very well, thank you. Nice presentation. Any questions? Ms. Holton-Hodgson, please. Go ahead.
So, thank you so much. This is terrific. One question for you. Do you have any advice, or I didn't see any messages about, being able to check if your doctor is in another plan? Because I know for many people that's obviously of concern. So this is switching your plan, but do you advise, and how do you even find out about, is your doctor in the plan? Sort of basic questions that you should ask yourself before you actually want to switch plans.
Yes, so the app does not currently provide that information. So to know if your doctor is in a different plan, members do need to go to look at all the different plan providers to see if there's overlap. But that is definitely something we've heard from our members and are working towards to have in future iterations for open enrollment. And actually not just for open enrollment, but all the time, where members can really shop around but keep the same doctor but pay probably the lower price if possible.
Would you possibly think about adding sort of questions you should think about as you determine whether you want to switch plans, or does that end up driving people in ways that you don't want to be responsible for? I mean, for example, if you're switching a plan, you need to think about your doctor, the hospital, whatever it is.
So there are disclaimers throughout, maybe not as easily displayed on the app, but that are online. With the comparison tool that provides a variety of information of all the different factors on what is different between the different plans, but ultimately it is the member does need to be informed, but we can definitely look to see if there's any ways we can improve that to make sure they are making an informed decision.
I appreciate that. I mean, I just think it's helpful, and I haven't been on the site because I haven't changed my plan in a decade. Here are the questions you need to ask as you think about whether or not you want to make a plan change.
Any other questions or comments? Mr. Jones.
Just outstanding.
Thank you. Thank you, Tim.
Very good. Thank you very much. Appreciate it. Brings us to item 7D, summary of committee direction. Ms. Bailey-Crimmins.
Mr. Fechner, I took one action item. So in November, we will bring back to the board, based on the reference pricing by pharmacy therapeutic class, to bring back details regarding pilot versus full solicitation.
Very good, thank you. Now we're at 7E, public comment. I have 4 requests to speak from the public. We'll start with Harvey Robinson and Stephanie Huig, please. Please come down here. You'll have up to 3 minutes. Your mic's on.
It's on already. Good afternoon.
Good afternoon.
My name is Harvey Robinson, and I thought I'd reintroduce myself to you, or introduce myself to you for the first time. I'm currently the RPEA Director of Health Benefits, recently elected. For purposes of past background, I'm 2-term president of RPEA, 1-term Director of Health Benefits. I also ran unsuccessfully to the CalPERS board. When I retired in 2001, I had 29 years of service with CalPERS, with the last 6 years with the Office of Long-Term Care. When I entered the CalPERS Long-Term Care program at age 51 in 1995, I elected the comprehensive lifetime plan with inflation at a premium of $77 per month. I now have a 10-year comprehensive plan at $275.86 per month. As you are aware, a partial settlement for the class action suit has occurred with the plan actuary, where members receive some $64.49. Should the class action suit be successful against CalPERS, the some 126,000 plan members would not be pleased if this resulted in increased premiums. Thank you.
Thank you.
Welcome back, Harvey.
I'm Stephanie Hughes, California State Retirees Executive Vice President, speaking for Tim Behrens today. I want to commend, where did he go? Robert, for the mobile app. Tim put the challenge out there on the table, and they picked it up and ran with it, and it's so far very good. I did like your comments, though, regarding questions you should ask, because they are very important questions. Members are experiencing numerous problems with this open enrollment period, and Larry will talk to you when he gets up here about all of those problems. CSR gave public comment in 2 prior meetings before the committee, expressing our surprise and concerns regarding the CalPERS abandonment of risk adjustment. It was rather sudden and not very well explained to us. You employed it for 5 years, you evaluated it annually, and you deemed it a successful tool in preventing carriers from cherry-picking low-risk members for coverage, and then you abandoned it. CSR, along with other retiree groups, objected to this matter in the manner in which it was canceled in a vote in a closed session at the Pension Health Benefits Committee in December 17, then not including it as a topic in the open session that followed, and then the cancellation was ultimately approved the following day by the Board of Administration. Again, without having it anywhere on the agenda, but rather included in the chairwoman's committee report, where it was briefly described as approved in closed session, moved and approved without any member questions or discussion, let alone allowing public comment. In April, when we learned of this action and complained, Mr. Jones did state in the June Pension Health Benefits Committee that CalPERS should make an effort to be more transparent in the future. We still don't have risk adjustment, and we still don't know why it was taken away. This action, I'm sorry, glasses, I forgot. This action has resulted in much higher premiums for thousands of members and beneficiaries, even though low-cost plans would see decreases. Lowering the premiums for lower and mid-cost plans did not help most retirees, since their premiums were already covered by CalPERS, or the state. Overall, CalPERS saves health plan fund monies by shifting costs to the members who must pay more out of pocket now and change to inferior plans in many cases. Paying more out of pocket is really difficult for people on a fixed income. And what we're meaning is when you go to see a doctor or a specialist, you're going to be paying extra due to these changes. Overall, oh, I already said that, never mind. Besides higher costs, thousands of members face other negative consequences, including plans leaving geographic areas or provider networks. Currently going through a Northern California issue where Anthem is not reached an agreement with the providers and the hospitals, and the members have until, October 5th to make their final choice about which plan they're going to choose, and Anthem is, they don't know. So we don't know if that's a viable option or not.
Your
We've
time
been
has
assured.
expired, Ms. Haig.
I'm sorry?
Your time has expired.
Oh, sorry.
Thank
Okay,
you.
thank you.
Thank you. The next two are Al Darby and Larry Woodson.
Go ahead, Larry. Go first? Okay. I'll put it on a positive note. Okay. Good afternoon, and Chairman, before you start timing me, if I could ask a question. I did ask for I'm not sure if you read it on my card, but I asked for 5 minutes if I could, because I'm going to tell some stories.
You just start and we'll see where we end up.
Okay, thank you. Larry Woodson, California State Retirees, Chairman Fechner, members of the board, thank you for the opportunity to comment. As Ms. Hughes stated, I have received a number of complaints and questions from our retired members. CalPERS Health Benefits staff implemented an aggressive communication strategy to inform those who will be negatively impacted by the cancellation of risk adjustment as well as other changes in 2019. And unfortunately, I'm finding that that isn't enough in all cases. There is confusion and frustration, and in some cases anger, among affected members, including active members, that has been drawn to my attention. It was reported in the Sacramento Bee that over 134,000 members were sent letters informing them of negative impacts due to health plan changes in 2019. 14,000 members in the Bay Area are losing their Blue Shield Access Plus plans. And the Bee article also stated that a Blue Shield spokesman attributed that decision directly to CalPERS' abandonment of risk adjustment. Now, although some retirees are affected, the vast majority of those 14,000 are active employees, which begs the question, were board members who represent those actives fully aware that thousands of their members would lose their plans when they voted to cancel risk adjustment? Some portion of the 14,000 will also lose their doctors if other affordable plans have different or more narrow provider networks. CalPERS rate charts show PERS care will increase by an average of 19.8%, but that's average. One active member is outraged that his family PERS care plan will increase 250%. If he switches to PERS Choice, he would still have to pay much more than he currently pays. I recently spoke to retirees, actually last week, at our CSR chapter in Stockton regarding health benefits for 2019 and their options. And one retiree and family on Anthem Traditional HMO was having difficulty interpreting the CalPERS material, even though I understand it. Some people don't, and the rate charts are very, there's a lot of data there. She was happy with her HMO traditional plan through Anthem and was inclined to keep it and pay a little more until I pointed out the little more she would have to pay amounted to $901 a month more out of pocket. That is even factoring in the monthly contribution. She doesn't like her alternative options as they have high deductibles and coinsurance, and some other basic plan members there were unhappy with their choices. 2 days earlier, I spoke to our CSR chapter in Chico and found even more confusion. First, some combo members had switched to the Anthem Traditional for 2018, which is being made available to them for the first time, which was great, and they were really happy to have it because it didn't have coinsurance and deductibles. Some received notices then of the huge premium increases, and after switching plans and doctors just 1 year later, they're now forced to do the same thing again or pay $225 more a month out of pocket. In another shock, just that week, their local TV news reported that Enloe Hospital, Chico's only hospital, had given notice to Anthem that it was terminating its contract effective November 1st, 2018. Members were afraid they were going to lose coverage. This was not communicated elsewhere. The next day at stakeholders, I shared this information, and Anthem's account executive confirmed to the staff and stakeholders that indeed they had received an intent to terminate and that it included all Anthem basic plans, including the PPOs. But he stated he was optimistic that agreement will be reached. If not, arrangements for coverage will be made in an alternate manner. We're not sure what that means. I've communicated that to Chico retirees, but things like this should not be occurring in the middle of open enrollment and without better communication than local TV news. In conclusion, CSR strongly objects to the cancellation of risk adjustment and requests reconsideration during the next year. We would like to meet with Health Benefits Management team to discuss this matter. And finally, we urge CalPERS to evaluate the early timing of its open enrollment and consider making it consistent with most all other open enrollments a month or two later to avoid unresolved contract disputes. Thank you very much for the time, Mr. Chairman.
You're welcome. Thank you. Mr. Darby.
Mr. Chair, excuse me, Mr. Chair, committee members, Al Darby, President, Retired Public Employees Association. I just wanted to thank the committee and the actuarial team for the recalculation of the East San Gabriel JPA termination fee that gave the retirees a 10% increase in their very impaired pension. So their haircut is not quite as short as it used to be. These folks are very grateful to CalPERS for revisiting this unfortunate situation. So thank you again for that consideration.
Thank you for your comments. Seeing no other requests to speak, this meeting is adjourned.